Good morning, and welcome to the Maryland Women's Coalition for Healthcare Reform's webinar series, Leveraging Healthcare Reform, Cultural Competency and Health Literacy Strategies. I am your host, Sandy Kick, Health Policy Analyst with the Coalition. Today, we are excited to present this webinar, the second in a four-part series on cultural competency and health literacy, and the importance of both in our healthcare reform implementation efforts. Today, we will present the Connecting with Consumers, Addressing Cultural Competency and Promoting Health Literacy webinar. First, we will hear from our speakers and then host a Q&A session before wrapping up today's webinar. Please note, we have muted all phones during the presentation portion of the webinar, but we'll provide you with instructions to ask questions when we get to the Q&A portion of the webinar. Now, I'd like to introduce Lenny Press, Chair of the Coalition, who will be our moderator today. Lenny?
Thank you very much, Sandy. And on behalf of the Women's Coalition, again, I want to thank everybody for joining us today. And I want to start by telling you a little bit about the Coalition for those that may not be familiar with it. On the next slide, we're a nonpartisan alliance of 94 organizations and thousands of individual members who are all working to ensure that every Marylander has access to high-quality, affordable, and comprehensive health care. We do that by raising the voice of women, and we include men as well, to get health care for all. And we're grateful to our members and our national partners for making that possible. And today I particularly want to thank who made this webinar possible. We achieve our mission through a number of ways, many of which you're familiar with, of four strategic areas: policy, legislation, engagement, advocacy, and action. And undergirding all of that is education, which is obviously the purpose of the webinar today. This is the second in a four-part series. In April, we presented the big picture, and you can access information on that on our website. Today, what we want to do is give you a national perspective of the federal requirements on cultural competency and health literacy, and we'll focus primarily on the cultural competency piece, and then provide you with the specifics of what's actually happening here in Maryland with Maryland Health Connection, our public web portal, and also the state's Connector program. And then we're going to finish up with a presentation that will give us a sort of on-the-ground look from the perspective of a connector entity. And as Sandy said at the end, we'll then open up the lines to take your calls. So let's get into the meat of this. We're very grateful for the four speakers who are joining us today. Mara Udelman with the National Health Law Program, a tremendous resource for all consumer advocates around the country. And then two speakers from the Maryland Health Benefit Exchange, Danielle Davis and Leslie Lyle-Smith, and then our connector entity representative, Sheila Makritich with Healthcare Access Maryland. So we're going to start with the federal perspective with Mara Udelman, who is the managing attorney in the Washington, D.C. office for NHELP. And I know many of you were on the call today because you saw that Mara is presenting, and that's not surprising given her expertise in the areas we're going to cover today. She serves as commissioner of the Certification Commission for Healthcare Interpreters. At NHELP, she's coordinated a national coalition to develop a consensus-driven agenda to improve language access policies and funding. She's co-author of Ensuring Linguistic Access in Healthcare Settings, Legal Rights and Responsibilities. And from the Commonwealth Fund, she reports on promising practices for providing language services. Mara is recognized as a national expert on language access and has participated on expert advisory panels for Robert Wood Johnson Foundation, the National Committee for Quality Assurance, and the National Quality Forum. So as everybody can see, we're extremely fortunate to have her join us, so I'm going to turn it over to you now, Mara.
Great. Thank you very much. And I'm going to, there we go. So good morning, everybody, and thank you all for joining us bright and early on a Monday morning. I'm very excited to be talking with you. I do want to emphasize that my presentation is really going to focus on the federal picture or the national picture, and then I'm really looking forward to our friends from Maryland who are going to be talking about specifics. The states have some flexibility within the federal standards to develop their own programs and training requirements. So I'll give you sort of the broad overview, but please keep in perspective that Maryland is implementing it in ways that are most effective for Maryland going forward. For those of you who don't know about NHELP, or the National Health Law Program, we're a national organization, and we've been in existence for over 40 years protecting the health rights of low-income and underserved individuals. And we're the oldest nonprofit of our kind, and we advocate, educate, and litigate at the federal and state level. Our language access work really spans over 2 decades, and you heard some of the highlights of it in the bio, so I'm not going to go into more details, but we do have a significant amount of language access publications available on our website, and I encourage you to take a look. In terms of the populations that are going to be served by the new health insurance marketplaces or the exchanges, they really are very diverse, and what that means is we really need to be thinking about how to do outreach and education to culturally and linguistically diverse populations to ensure the overall success of healthcare reform. So as you can see from this slide, the people who are coming into the exchanges are more racially and ethnically diverse than other privately insured populations. About 1 of every 4 exchange applicants speaks a language other than English at home, and 95% of the uninsured LEP, or limited English proficient individuals, are less than 400% of the federal poverty level, and therefore will be eligible for help paying their premiums. And again, they're going to need education and information in their languages to ensure that the applications and information they submit for eligibility is accurate, and so they get the maximum amount of help that they are entitled to. So really, really briefly, as I think a lot of this was covered on the first webinar in this series, we're talking about exchanges or marketplaces. That's, again, the federal term here. And what this is, if you think really of like Travelocity or Hotels.com, it's a single point of entry for individuals to go and to apply for health insurance, and then if they're determined eligible, to actually select a health plan. For individuals who already have insurance through their employers or through one of the public health programs like Medicaid or the Children's Health Insurance Program, nothing's going to change. This is really for folks who are uninsured. And there will be assistance to help pay for premiums and also for cost sharing for lower income individuals. And I'm briefly going to go through some of the federal requirements to provide language services and to help individuals with disabilities, which are governed by federal civil rights laws, as well as a specific provision in the ACA, which is the Affordable Care Act, or the shorthand version of the federal health reform law's name. So in terms of the laws looking at language access and cultural competency, we have Title VI, which many of you may be familiar with since it's from 1964. We have Section 504 of the Rehabilitation Act, which governs accessibility for individuals with disabilities. And we also have a number of specific Affordable Care Act or Obamacare provisions as well as regulations. And I'm going to walk you through some of those, and then we'll hear more about what Maryland's doing to implement these and other culturally and linguistically appropriate services. So in terms of Title VI, Title VI says if you take federal funds, you can't discriminate on the basis of race, color, or national origin. And this includes individuals who are limited English proficient based on longstanding federal Supreme Court law, as well as policy from the Federal Department of Health and Human Services. So any program that takes federal funds, which includes all of the state exchanges, including Maryland, because they got federal funds to set up their exchanges, must make sure they're not discriminating on the basis of language or race or ethnicity. In addition, we have a specific non-discrimination provision that was enacted as part of the health reform law, and this is Section 1557. And it builds on Title VI and other pre-existing civil rights laws, and it says you can't discriminate on the basis of race, color, national origin, gender, and disability. Similar to Title VI, it's linked also to federal funds, so that's this first sub-bullet here. Any program that receives federal financial assistance can't discriminate. It also goes a step further and specifically says any program or activity administered by a federal executive agency, like the Medicare program, or in states that don't have their own state-based exchanges but are asking the federal government to run their exchanges, that federally facilitated exchange, or FFE, can't discriminate. This provision also explicitly applies to any entity established, and this is the legal jargon, Title I of PPACA of the Affordable Care Act, but the shorthand version is because these exchanges or marketplaces were created in Title I, they also can't discriminate. We haven't seen explicit regulations come out at the federal level, but we expect those this year. But many of the regulations that are implementing health reform have provisions in them prohibiting discrimination against these individuals. I will also say that while this provision doesn't explicitly cover discrimination on the basis of LGBT status, the Equal Employment Opportunity Commission ruled that discrimination because someone is transgender is sex discrimination, and thus it's covered by these other civil rights laws. And then HHS's Office for Civil Rights has included discrimination based on sexual orientation or gender identity because this specific provision covers gender identity discrimination. So while you might not see LGBT status in what's bold and underlined, we have some interpretations by the federal government that does make it clear that discrimination on the basis of LGBT status, sexual orientation, or gender identity is also prohibited by 1557. We also have Section 504 of the Rehabilitation Act, which I didn't include a slide on, but that again prohibits anyone who takes federal funds from discriminating against individuals with disabilities. So in terms of who's covered by these laws, again, it's all public and private entities that receive federal financial assistance. So as you can see, it includes federal agencies, state Medicaid and CHIP agencies. Whoops, sorry, I went a little too fast there. Let me go back if I can. There we go. State exchange and connectors, including their staff, their call centers, and all of their subcontractors, the qualified health plans that participate in the exchanges, and then all assisters who are going to be contracted to provide help. So we also have some specific provisions that actually say culturally and linguistically services must be provided. And two of these provisions relate to group health plan appeals and the summary of benefits and coverage. And these are actually put into federal regulations, and it says if you meet a threshold language, then a participant can request a translated notice. So if a health plan is trying to deny someone a service, and that individual files a complaint and requests an appeal of that decision, that individual can get a notice translated into their language if a threshold is met. The regulations also require taglines on all English notices in the threshold languages. So, for example, if all the notices are going out in English, there might be a tagline in Spanish that says, this notice is important, and if you can't read it, please call 1-800-INSURER to get help. It also says that oral assistance, so interpreters or competent bilingual staff, must provide assistance for threshold languages. Now, we've seen a little bit of a problem with the threshold that was initially adopted by the federal government, which was 10%. And unfortunately, a 10% threshold leaves out millions of LEP individuals. As you can see from this chart, when HHS did its analysis, using a 10% threshold means you only are required to translate materials or provide oral assistance in 255 counties across the U.S., 78 of which are actually in Puerto Rico. We've been advocating for use of lower standards based on pre-existing HHS and Department of Labor standards. And as you see, if you use a 5% or a 500 LEP person threshold, you hit much higher numbers of counties where information would be translated. Again, this is important because it was specifically put into regulations for appeals and the summary of benefits and coverage. But going forward with the activities of the marketplace and the connectors and navigators, we really do strongly believe that we need to have better standards in place to provide language services. There's another provision in the Affordable Care Act that specifically looks at data collection. And again, this applies to healthcare programs, activities, and surveys, and they all must collect race, ethnicity, primary language, sex, disability status of applicants, recipients, or participants. Collecting data is really important to identify if there are health disparities and then be able to assess and put in place the proper plans to address them and prevent them from going forward. So I want to switch gears a little bit and talk about helping consumers. Some of you may have seen that actually early this morning the federal government relaunched its main health reform website, which is called healthcare.gov. And throughout the summer and the fall, there really is going to be a huge push at the federal level for outreach and education, as well as at the state level, to help consumers get ready for October 1st, which is when the first open enrollment period starts. There are going to be many entities who will be helping consumers understand their options, apply for insurance starting in October, and then select health plans. Some of these are entities that actually are connected directly with the health insurance marketplaces. So it may include exchange call centers and their staff. As we'll hear about shortly, it also may include like navigators and assisters who are contracting with the state exchanges. But there also are likely going to be other entities that may provide more informal enrollment information without being officially contracted. So this may include, for example, legal aid organizations, churches, community-based organizations, disability-focused organizations, etc. And so it's really important that we get all of these different entities the most current, accurate, fair, and impartial information so they can help consumers prepare. So again, what I want to go through very briefly are the federal requirements for training for assisters. And there's 3 different categories of groups that can provide directly provide assistance to consumers looking for help. The first 2 groups are called navigators or in-person assisters or IPAs. And again, according to draft federal standards, they must have at least 30 hours of training. Marilyn will probably talk about what it's going to be looking at in terms of training, and it needs to have some of the same standards as the federal government, but also has some flexibility in how the training will be delivered and the length of the training. So according to federal standards, they must have at least 30 hours of training, which will include providing culturally and linguistically appropriate services, ensuring accessibility, and working effectively with limited English proficient individuals. There's also specific requirements for providing culturally and linguistically appropriate services and ensuring access for people with disabilities. We're waiting for those final federal regulations, and then again, Maryland can develop its own training programs with HHS approval. You may also have heard that there's going to be sort of no wrong door when open enrollment starts on October 1st. And one of the main reasons we get that is we don't want someone to have to come to an exchange and then be said, oh, actually, you might be eligible for Medicaid. We're going to send you somewhere else. Well, you're slightly higher income. We've got to send you somewhere else. The idea of health reform is to have one point of entry, and regardless of what program you're eligible for or how much financial assistance you may get, you can do an application wherever you show up. And so one goal towards meeting this is to have a single streamlined application. And again, I'm talking about the federal version of the single streamlined application. The federal version is the default, but if a state wants to adopt its own application, it can do so if it gets HHS or federal approval. On the federal single streamlined application, we do have collecting language data, but unfortunately it's only collecting it of the household contacts. They are collecting race, ethnicity, gender, and disability data of all applicants. We feel very strongly that the language data should be collected of all applicants, and as I mentioned earlier, there's that provision in the ACA that actually seems to require that, and we hope that that will be fixed sort of in future years. The federal single streamlined application is only going to be available in English and Spanish. The federal government will be developing an education or outreach tool available in 7 other languages. It basically would be a translated version of the application, but you can't submit an application in Chinese or Korean or Vietnamese. Instead, you can use that version and then fill out the English or the Spanish application. And HHS is also going to support the development of the tool in 17 additional languages. And as I said, states can seek HHS approval for alternate applications. So as I mentioned very much at the beginning, we have a number of resources available on our website. We've provided a checklist for marketplace implementation of language access and for ensuring accessibility for individuals with disabilities. And we've got some short papers analyzing some of the language access requirements. So at this point, I will turn it back over to Lenny, and thank you very much for listening, and look forward to hearing more of the specifics of Maryland coming up.
Thank you, Mara. That was terrific and a great platform for the other presentations. So we want to turn to Maryland now. And as Mara made clear, Maryland has flexibility in what they're doing, so that some of the terminology and what's going into the application and so forth will be different. So we're extremely fortunate to have, I think, 2 representatives from the exchange with us today, and we really appreciate your taking time to join us because we all know how busy you are. So Leslie Lyle-Smith is the Director of Operations at the Maryland Health Benefit Exchange, with oversight responsibility for the Connector program and other consumer assistance programs, including the call center, and you saw her picture briefly. Previously, she worked for an MCO in D.C. And at DHMH, before that as Deputy Director of Program Operations. And then joining her, Leslie will speak first, and then joining her and taking over will be Danielle Davis, who's the Director of Communications, Outreach, and Training at the Exchange. She previously developed integrated marketing and public relations campaigns for clients and organizations in the healthcare, technology, and consumer products and professional services sector. And we've seen some of the great work on the communications, education, and outreach coming from the Exchange. So I'm going to turn it over now to Leslie and Danielle.
Great. Thank you, Lenny, and thank you for allowing us the opportunity to speak this morning. This is Leslie Lyle-Smith, again, Director of Operations for the Maryland Health Benefit Exchange, the Maryland Health Connection Program. And I just want to kind of level set as far as Maryland's terminology for the different entities that will be helping with the Consumer Assistance Program. So as mentioned, there are going to be multiple resources that will be available for consumers who need assistance with understanding their insurance options. We will have the online option at the marylandhealthconnection.gov, as well as in-person assisters. And I'll go through just so that everyone has an understanding of the different terminology and the different roles that each of our in-person assisters have. The Connector program, which is made up of navigators and assisters, application counselors, insurance producers, which are considered brokers or agents, and captive producers. And then lastly, we'll talk a little bit about the Consolidated Service Center, or our call center, which will be responsible for fielding all of the calls from consumers regarding the Maryland Health Connection program. So next, the slide will catch up with us. So next we have just an overview of the Connector program. It was formerly called the Navigator program, and our Connector program now has two components. The Navigator program, which again is made up of certified individual navigators and licensed shop navigators, and then the in-person assistance program, which is made up of assisters who will perform outreach and education duties and facilitate eligibility determinations, and of course non-certified personnel who will provide support services. We awarded 6 Connector entity grants to entities in 6 regions throughout the state of Maryland. The map, as indicated here, in our central region, we have Healthcare Access Maryland is the Connector entity. In the southern region, which is the gold color, Calvert Healthcare Solutions. The upper shore is Seedco. The lower eastern shore, which is the purple color, is Worcester County Health Department. The western region, Healthy Howard, and the capital region, Montgomery County Department of Health and Human Services. So let me just take a few moments to really talk through what the differences are between the different roles. So the navigators and assisters, if you remember that the navigators and assisters work through the connector entity programs, and those personnel will be funded through the grants that we provide through the connector entities. So there will not be any individual navigators that are kind of working out there alone. They all must work through a connector entity. A navigator has several responsibilities, including conducting public education and outreach, making certain that they provide fair and impartial information, so all of the health plan information that consumers can choose from, the navigator must be fair and impartial and not promote any one health plan. They will facilitate enrollment into health plans, so into the commercial qualified health plans. That is their part of their responsibility. They provide referrals for grievances and complaints and questions, and they must provide information in a culturally and linguistically appropriate manner. And that's true not only for navigators, but everyone working in the Consumer Assistance Program. They have to maintain expertise in eligibility, enrollment, and program specifications, and they refer insured small groups and individuals back to the producers. And we'll talk a little bit more about that later on. There will be, as mentioned, a certification process for navigators that they must pass in order to actually become a navigator, as well as training that goes along with it to ensure that they can successfully execute all of the duties as mentioned above. Then moving on to assisters. Again, assisters are engaged through the connector entities, and they, too, can conduct public education and outreach. They can facilitate eligibility determinations for Medicaid and MCHIP and provide ongoing support. So the difference between a navigator and a assister is essentially that the navigator has the ability to facilitate eligibility and enrollment into qualified health plans, whereas an assister cannot. An assister can only facilitate enrollment in Medicaid and MCHIP and determination for subsidies. So moving on to the next group of roles are the application counselors and the insurance producers. So the application counselors, and if you just a quick way that really helps me to remember it, they do the same thing as navigators. The difference is that they are not paid through the connector entity program. So these are individuals that may be affiliated with a hospital or a health center who will get certification to be able to facilitate enrollment, but are not paid by a connector entity grant or the Maryland Health Benefit Exchange. And this was a relatively new role that was introduced by the United States Health and Human Services just recently in the past couple months. The insurance producers, or sometimes called agents or brokers, they will serve a very important role for the Maryland Health Benefit Exchange. They will continue to work with our small group customers as they do today. They can become registered to become authorized to sell qualified health plans of the Maryland Health Benefit Exchange, and they will continue to be compensated by the insurance carrier. So they will not receive any funding from the Maryland Health Benefit Exchange, and they will continue their current compensation structure. And again, there will be a licensing program and training that will be provided to them. Next on to captive producers. And captive producers, their role is a little special in that they will specifically work to help transition an insurance carrier's existing enrollees into the Maryland Health Connection program. And they can provide enrollment assistance only to those individuals who come in contact with that insurance carrier or who are already enrolled with that particular insurance. They must act in the best interest of the consumer. They have to disclose their employment with the carrier at the of conversation with the consumer, and they are subject to the same restrictions and regulations as the navigators. and they too will need to have the same licensing and authorization requirements as authorized producers. There are also certain criteria that the carriers must do, and that's document and retain records of such disclosures and provide disclosure records and updated list of captive producers to the Maryland Health Benefit Exchange on a regular basis. And should they not be compliant with such of these regulations, there may be sanctions that may go into effect as a result of that. And we're hearing this beep, so I'm not sure if everybody else is hearing that. So we'll move on to the Consolidated Service Center.
Women's Wellness.
Hello?
Hello. Hold on.
No. Can we all just leave?
I'm still here. Can you still hear me?
I'm sorry. I'm sorry to those on the webinar. I don't know who's calling in, but I think you have the wrong line.
No, I think someone put us on hold, the Women's Wellness something, because it just sounded like they picked it up, but they don't realize that it's a webinar for some reason.
So can I ask you to go off the call and see if that rectifies our problem?
Okay, and you want me to continue, Lenny?
Yes, thanks very much.
Okay. And then lastly, the Consolidated Service Center, or our call center, will provide consumer assistance role as well, in that they will be available to consumers, small businesses, navigators, assisters, to answer any questions and to assist consumers as well in the enrollment process for the program. It will be a toll-free hotline that will have the ability to be linked in and will provide assistance for consumers to enroll into the Maryland Health Connection program. The call center will have language line services, so any person that calls in that speaks a language other than English will be able to have assistance with a interpreter for language line services. There will also be a complement of Spanish-speaking bilingual representatives that will also be available. There will be TTY services for those that are hearing impaired. There will be extended hours during open enrollment. Matter of fact, we will be open 7 days a week during open enrollment. And we will just have a lot of coordination with the insurance carriers and all of the connector entities. So this will be the hotline center and just really a one-stop shop should any consumer or small business need any assistance. And the call center is scheduled to have a pilot launch in August, whereby the call center will be answering questions related to any of the outreach or marketing information that is outside in the community regarding the Maryland Health Connection program, and they'll be able to answer any questions. And definitely they'll be up and running by October 1st for enrollment. So I will turn it over to my colleague, Danielle Davis, who will get into a little bit more specifics regarding the cultural competency aspects.
Great. Good morning, everybody. Thank you, Leslie and Lenny. I want to thank the Women's Coalition for hosting this event this morning and for inviting both Leslie and myself to participate. And Mara, thank you for your opening section. That was really helpful, and we appreciate it. My section of the presentation is going to focus on Maryland's efforts to ensure the cultural and linguistic competency of Maryland Health Connection and the implementation here in Maryland. So I'm just going to continue on from where Leslie left off and talk a little bit more about what we're doing here in Maryland. So as Lenny said earlier, my name is Danielle Davis. I'm the Director of Communications, Outreach, and Training for the Maryland Health Benefit Exchange. I'm responsible for the communications, marketing, and also the training for consumer assistance individuals, the navigators, assisters, application counselors, insurance producers. With Leslie, I'm on the executive team at the Maryland Health Benefit Exchange. We have both been very much involved in the policy development around the Connector program, and for over a year now working through the development of the program. So I just want to talk a little bit more about the Connector entities, leading on with what Leslie was talking about, and ensuring that the cultural and linguistic needs of consumers, individuals around the state are met through this program. Leslie had mentioned the 6 regional entities that are on board with us to deliver consumer assistance, the navigators and assisters throughout the state. And working with those 6 organizations are an additional 50 or so organizations, subcontractors or partners that are working with them to ensure that the needs of the most vulnerable individuals within the state are met. So those are individuals with that are in the most remote areas of the state, individuals with disabilities, with special needs, that we know are going to need assistance with enrollment, that may have difficulty with the application process, or may just be difficult to reach through standard communications practices. So we're working very closely with the Connector entities to develop those plans and to implement the program. So on this first slide that I'll talk about is as we developed the program, one of the first things that we looked at were the language needs in the state of Maryland. And if you look at the total population that we were working with at the time, it's roughly 5.5 million. And we looked at the various language populations, both languages spoken at home as well as the limited English proficiency. And we look at the threshold. Clearly, we have a Spanish-speaking population in Maryland of roughly 7%. And then we go down into some of the other languages. We do not have high thresholds in the state of Maryland overall in the state of Maryland, but we do know that in particular areas of the state there are pockets or high concentrations. And those are the populations that the Connector entities in their programs within their communities, within their regions, will be focused very specifically on communities that have specific language needs. So they'll be working with those communities. Overall, in our communications and outreach efforts, our materials will be in both English and Spanish for this reason, but we will be working with the Connector entities to meet some of the other language needs as well. As Leslie mentioned, the call center that will be opening in August, we'll have a language line, and that language line will provide translation services for 35 different languages. So if somebody has a need for translation, we will be able to meet those translation needs. It will also have TTY for the hearing impaired as well. Additionally, we will be providing materials for the visually impaired, for the blind, so we are producing materials for those with disabilities. I just also wanted to share with you some data on the next couple of slides about the state population. We know that in the state of Maryland, a very diverse population. In the age group 18 to 64, we know that roughly 14 to 15% of the population is uninsured. And this really helps us with our planning, both from the regional approach where we know that consumer assistance is needed, and also in our overall planning for cultural competency. It also is very important when we look at the, in terms of plain language needs, in terms of education, attainment, and how we develop our materials. So just wanted to share some of this data with you. We know that 24% of the population in Maryland between ages of 18 and 64 have less than a high school diploma. 32% have completed high school, and 25% have some college or an associate's degree, while 18% have a bachelor's degree or higher. What we were able to do on the last round of research that we completed, we conducted an environmental analysis in November of 2011, and we updated that in March of 2013. And what we were able to do when we updated in March of 2013, as we brought the connector entities on board and we had this regional approach of the 6 regions, is we were able to apply look at the data on a regional basis, which has been really helpful in our planning. And you can see on this slide here the breakdown in population, both by race and ethnicity per region, which is really, really important to be able to see across the state how this breaks out. And I'm not going to go through this because I know we're running short on time, and I want to make sure that we get to Sheila, but you will have this in your packet I think on the website when these are posted. This next slide really gives us a very clear indication also on a regional approach. As you go across the state, and again, on a regional approach, per region, when we think about where the uninsured live and who we know will be eligible for Medicaid and for advanced premium tax credits and subsidy or cost-sharing reductions, and this is really important as we develop our communications and our outreach strategies, and this is really important in terms of cultural and linguistic competencies. It gives us a clear indication region by region, and you can see here, for instance, in the capital region, we know that 50% of the uninsured population will be eligible for financial assistance, while 28% is expected to be eligible for Medicaid. On the lower Eastern Shore, for instance, we can see that 46% will be eligible for tax credits, and so on and so forth. So as we develop our outreach strategies and we work with the connector entities, we can plan very, very succinctly how we will go about our planning for the campaign. On the next one, we also look at race and ethnicity by region, and you can see the breakout changes very dramatically as we go across the state. And the diversity of the state is very unique in Maryland, region by region. The one thing that we know when it comes to cultural competency and linguistic competency, health and financial literacy for Maryland Health Connection, we know that we have to develop a campaign or a program that has several components to meet this diverse population for Maryland and also meets the Affordable Care Act requirements. And the connector program is a really important component of that, the consumer assistance component. We know that the exchange, the rate plans will be based on quality and will price the benefits of those plans. The consumer assistance that will be available will help guide consumers through that process. The navigators and assisters play a really important role in that. Online calculators will be available to help people. So there are elements of the program that are really important to begin to help people overcome some of the burdens, some of the obstacles that will be in their way. There's a lot of skepticism we've learned through our research that we know we need to overcome. But cultural competency, we know that in our marketing and our communications materials, we need to really address through some of these, through some of the cultural and linguistic components. So what we're doing is our campaign is very integrated. We have advertising, there's a communications aspect of it, community outreach. We're developing a lot of partnerships with state and local agencies and working with the connector entities as well on the ground, whether they're health centers, local programs, health and wellness programs, really looking for kind of the boots on the ground so that we can educate consumers and small businesses about health and financial literacy to really overcome some of the skepticism and uncertainty that people are experiencing.
digital and online marketing, really trying to understand where people live, work, and play, where they worship, trying to really understand how it is that they will make this decision and overcome any of the skepticism that they may be experiencing. Some of the basic needs that we know that consumers have right now is that they need to understand the benefit structures that they'll be facing, the cost-sharing reductions. They need to understand the health insurance terminology, the coverage rules. They've never heard of this. This is something that's brand new to them. So what we're doing when we develop the cultural competency aspect of this is we're dividing it into kind of 4 parts of the program. So we're looking at the diversity of the population of the state. We're working in an assessment component into the program. And then there's the training that Mara talked about earlier, which is a very, very important part of the program. And then the structure and the policy component when it comes to cultural and linguistic competency. So I'm just going to quickly talk through those 4 components. So for diversity, the Communications and Outreach Campaign is designed to meet the needs of the state's diverse population. And we looked at some of the slides a moment ago about race, ethnicity, lifestyle, age, gender. The geographic diversity of the state is very important. We know that as we develop the mechanisms of how people enroll, how they'll access consumer assistance, how we communicate with them, it varies from one region of the state to another. What works on the lower Eastern Shore is going to be very different from what works in an urban community or a suburban community. So the geographic diversity of the state is very, very important. And then the language needs also of individuals in the state. And then disabilities, those with those that are blind and visually impaired, those with hearing disabilities, and other disabilities as well. And then the plain language standards, and then also those with limited English proficiency. The assessment part is also very important when it comes to the cultural and linguistic competency. I had mentioned the formative research earlier. We have conducted a tremendous amount of research. The environmental scan that I talked about earlier, we've updated twice. We've conducted focus groups throughout the state on several occasions, and we're getting ready to do another round of that. We've also done quantitative research, a needs assessment, in-depth interviews, IDIs, audience profiles, all of this to really understand the cultural needs of the population in Maryland. And then there's an assessment component of this, and this is a really important part of our program. And this is a tool that we're developing to really identify the opportunities for improvement. And what this does is it's an assessment tool for cultural competency that will be scoring all of our materials as we develop them to understand everything that we do. Does it meet the cultural competency of the population in Maryland? Does it meet their needs, and how can we improve on them? We want to make sure that the examples that we're using in our materials are familiar to the intended audience, that we're using quotes and personal stories that effectively connect with the audience. People trust family members and people that are like them, that we're using images or voices that represent the intended audiences, and that the references that are culturally acceptable to them. So this is all part of the cultural cultural competency program that we're using. And then finally, I just want to talk about, the last thing on that was the style guide, and that's a really important part of this as well, the cultural competency tool that we're using. And this is a style guide that we're developing that's part of the program that guides all of our communications and is tested for cultural accuracy and tested as well. And this applies not just to the materials that we're developing, but also to the actual enrollment site. So that is constantly being reviewed in the language, checked for accuracy and updated to ensure that it's written at the appropriate grade level, that it's, meets plain language standards, and that it's easy to understand and use. Again, that usability and readability standard. And then lastly, I believe this is the last part, is training. And this is a really important part. So this applies to all of those that will be delivering consumer assistance. So those are the navigators and assisters, application counselors, producers, and others. And it's really important when we talk about how people acquire and institutionalize the knowledge. And the cultural competency, linguistic competency is really, really important, as we know. And the training protocols that we're developing, there will be specific components of the training that involve the cultural competency, outreach and education, health insurance and financial literacy. So the individuals that are going through training will receive specific modules or training curricula that are unique to those core curriculum components, and then they will be tested and evaluated on those and responsible for those portions of the training program as we go through the training program. And then finally, I just want to talk about the structure and the policies. And, as we talked about the 4 parts of the cultural competency program for Maryland Health Connection, this is kind of that 4th pillar of our program. And it's really important because as we talked about the connector program and how all of this was being developed, it really is the cornerstone of it, because the connector entities and the organizations that are working with them are really, as Jill is going to talk about in a moment, kind of the boots on the ground and the people that know their communities the best. And as the program was developed, it's really this regional, community-based approach. The roles of the navigators and assisters. So you see this streamlined approach to really understand and meet the needs of those in the local communities and meet the cultural needs of those in their communities. And then the consumer assistance program as well that Leslie talked about with the call center. So really striving to meet the cultural needs and meet the needs of those that we're serving. And then, of course, the requirements of the ACA. So, it ties together with our outreach and communications program and the materials that we're developing. So I think I'll end there because I know that we're running short on time. So I will end. Thank you.
Thank you, Danielle. That was enormously helpful. And as Danielle suggested, the presentations will be up on our website afterwards, and I'll refer back to that in a minute. So let's turn now to what it's going to look like on the ground with one of the connector entities. And for anybody who's been working in Maryland for a while, you're familiar with the excellent work of what was Baltimore Healthcare Access. And with passage of the ACA, they changed their name, took a broader scope, and are now Healthcare Access Maryland. Sheila McErtich, now Vice President of Health Reform Initiatives at HCAM, came in 2011. And since then, she and all the other consumer advocates have attended virtually every meeting relating to the exchange in healthcare reform. So she's well-versed in all of the intricacies of implementing the Consumer Assistance Program and applying the standards of cultural competency and health literacy. So we're very grateful that she could take the time today. And so, Sheila, I'm going to turn this over to you.
Great. Thank you. Good morning to everyone, and certainly thank you to the Women's Coalition, to Lenny and all of your group for extending the invitation for healthcare access to participate today. Thank you to the previous speakers for really setting the table. Healthcare Access is thrilled to be the connector for the Central region and excited to be part of this very cutting-edge initiative and really extending the work that this organization has done for many years of connecting people to health insurance. So a little bit about Healthcare Access. So that is the core mission of this organization. We were established in 1997 as a nonprofit agency at the time by the health officer in Baltimore City, Peter Bielenson, specifically to handle 2 core grant programs. One was eligibility, so connecting people up to Medicaid, enrolling them into Medicaid, and then those that were in Medicaid, making sure that if they were lost to care for some reason, that we reconnected them to care. So we reached out to, we were working in the Baltimore City area for many of those first 10 years or so, and then realized that we wanted to start expanding our reach. We were frequently reached out to see if we could work in other jurisdictions. We rebranded. We're now Healthcare Access Maryland. We've grown from about 3 million to about 23 million and have 19 programs, and many of those programs all with the core mission of connecting people to health insurance, but helping a variety of targeted populations. It could be the homeless, it could be those that are drug addicted or have substance abuse issues, it could be people in the maternal and child health area, foster children, but all of our areas of expertise focus on eligibility and enrollment, navigation of the healthcare system, care coordination, and then ultimately education and advocacy. We are very diverse and culturally competent staff. We'll talk about this in a minute, but this doesn't happen overnight. This organization has, again, been around for 15 years, and it is always on the front burner to ensure that we're particularly sensitive to the many ethnic communities in our region. And again, that's been broadened out to Baltimore County as well as Anne Arundel County with the Connector Grant, and really before that, because we do have programs in both counties today running. But it's not an overnight thing, so it's always something we're very sensitive to and try to keep our eye on the ball with regards to ensuring that we continue to ensure that our staff is culturally competent and that we're focused on health literacy and the varying and changing ethnic communities in our region. So for the Connector Grant, we, as noted earlier, it does include the 3 jurisdictions, and we do have 17 partners. I certainly won't go to any length of all the great commentary that Leslie provided on the navigators and the assisters, but our particular proposal includes 107 combined navigators and assisters. It's really kind of cut down the middle, 53 and a quarter navigators, and then the other 53 or so in assisters. A majority of our partners employ the assisters, and HCAM's employing a majority of the certified navigators, but all of them with the roles that were identified by Leslie, very focused on the local communities. So with our partners, we have 17 formal partners. The only distinction between formal and informal is that the formal partners will receive funding from the Connector Grant, and informal partners will actually deploy human resources. I expect by the time open enrollment starts, we'll have probably an additional 50 informal partners spread throughout the 3 regions. We get calls every day from organizations that would like us to partner with them, and that doesn't even include maybe one-off occasions where we help in the faith-based community, attend events, that type of thing, but I'm talking informal partners where we regularly send out staff to assist. When we were choosing our formal partners, we made a very concerted effort to make sure that varying populations were addressed, areas that HCAM certainly couldn't do on its own, organizations that had expertise serving these communities in the past successfully. So organizations like Healthcare for the Homeless, reaching out to the homeless population, what can be a very hard-to-reach population, is one of our partners. Smaller community-based organizations that the community is very familiar with and comfortable working with, like Park Heights Community Health Alliance and Charm City Clinic. Again, they know their communities, and though we'll partner with them, we will lean on them to reach out to that community. And then, as mentioned several times with regards to the disability community, we found it really important, regardless of what's in the state exchange training, that we focus additional training on those with physical and intellectual disabilities, and we are partnering with 2 organizations, one, the Coordinating Center, who has decades of experience working in the disability community, who will help with additional training of our new workforce, and then the Mental Health Association, who will also help us with additional training for our workforce, understanding the complexities of both communities and wanting to make sure that we reach out appropriately to those communities. All of the partners have demonstrated some experience in the past with reaching out providing services to the community. Many of them have very diverse staff. Many of them, like Baltimore Medical Systems, have bilingual staff in many different languages, not just Spanish. And so it was really important for us to have a complement of organizations that were able to not only reach specific targeted communities, but also have the ability for us to tap into with regards to the diversity and potentially leaning on them a little bit if we feel there are other gaps that we can't serve as an organization. So we talked a little bit about the fact that we'll have 107 certified navigators and trained assisters. Fortunately, here at HCAM, we have an established organization, and we have 200 employees already providing a lot of outreach and education, and we can fortunately leverage some of those resources with regards to the diversity, with regards to the bilingual staff that we already have on board. And we have currently today an immigrant services unit. They are deployed, working with varied partners right now in the Baltimore City area. We're actually looking at a model now where we'll break up that division and spread them out more throughout the organization so that we can leverage them even better. But because of that, it makes it a little bit easier bringing on a new workforce, because we really will be able to utilize existing staff that have much experience working with varying ethnic communities, and as well as helping us as we're training and moving forward very quickly towards open enrollment. And we talked about the fact that they will be providing education and outreach, eligibility, and then facilitating the enrollment of the 220,000 or so individuals in the central region. I'm not going to go through all of the points that Leslie did. I put this back up there, though, because the reality is when it comes to a diverse staff that must be equipped to be culturally competent and reach out to differing ethnic communities, it threads through all of this. So, every piece of this that's required by the navigators and the assisters, at any point, we're potentially helping someone that has limited English proficiency, that has needs that are not necessarily going to be straightforward, and we need to be able to assist them regardless. So all of these really black and white requirements are always a little bit more complicated, because we need to make sure we are addressing the needs of the underserved communities, very vulnerable populations at times, those who need minimal assistance, the cultural differences, all of that, and all of these functions we have to be sensitive to as we're trying to train people and get them ready to be really out on their own, working in external organizations day after day after day. As a reminder, they won't be sitting in an HCAM office. They won't have direct oversight over them. So we have to get them up and prepared to be out there and comfortable on their own. So that leads us to some of the questions that we ask ourselves daily as we're putting this together, and really is that the organization has been asking itself for the 15 years of its existence. It takes time, so this endeavor to pull this up and running in a few short months, we have the fortunate experience of having an organization that's been doing it for 15 years. So I'm very lucky from that perspective. It does not happen overnight. Putting someone through a class on cultural competency, unfortunately, is probably not enough. And so we have to make sure that we are not only making sure that they have the training, and HCAM's been doing training like that for years, but we're lucky enough to have the additional training from the exchange, but that after that training, we need to make sure that people are being shadowed, who are working in different ethnic communities by individuals who have done that work in the past, so that we know for sure that they're comfortable working with the clients that they've been assigned to work with. Who are we hiring? There's great intention as we're going through this hiring process. We're pulling on board about 40 new people in about an 8-week period of time. So we have great intentions and focus when we're meeting with people and speaking with them to make sure that when someone says they're bilingual, that's great, but when they say they're bilingual, are they able to really speak in the dialect that in the many communities we face in the Baltimore City region alone will be understood? Or is it someone who took advanced Spanish classes as they were going through college? And there is a distinction, so we need to really understand what people's skills are and what their abilities are. So who are we hiring and how are we training? Again, we'll have the exchange training, we'll have the internal HCAM training, but then we'll have that additional shadowing and support of team members here at HCAM that have done this work in the past. It's certainly not a cookie-cutter approach. One community is not the same as another, regardless of the primary language that's spoken. Most of the bilingual staff here at HCAM come from many different countries, some of them born here in the U.S. and very fluent in Spanish, very much living in a Latino community. We want to make sure we're not translating, but that we're communicating. And that is a big difference that we face every day as we're face-to-face with clients, as well as we are taking any new materials we have and creating Spanish versions, that one word can make all the difference. So how we're speaking to people and how we're putting together our materials, we always ask ourselves, we always ask multiple individuals that are bilingual to look at our materials to ensure that we are actually communicating what we intend to communicate. Peer-to-peer coaching and mentoring has been the key to our success. So, we have bilingual staff here that have worked here for years. They're always excited and willing to help peers that are new to the organization, new to the different communities, to work with them and mentor them. And I would say that's crucial in the success of the organization. And it's all about relationships, really, in anything you do. But with regards to our advocates, the community has to trust them. We ask ourselves all the time, do we know the community we are sending advocates out to, or are we just dropping in? And if we're just dropping in, then there is no trust, and people are very, very hesitant to share personal information and certainly to sign papers and enroll into insurance. So our advocates that work in the Latino community in Baltimore City, they know those communities. They don't just know the language. They don't just know some of the cultural differences and traditions. They know the community. They read the newspaper that is specific for the community. They listen to the radio station. They know what the local laundromat is. They know where people go food shopping. They know the community. It is crystal clear, and that is core to the success of those individuals, because if you shadow one of them when they're doing their outreach, the people that they provide services to are very relaxed and have a true conversation with our community advocates, because they know that they really are familiar with the community and are not just dropping in, passing out information, and then leaving. And what are our advocates telling us about the needs and concerns of the community they're serving, and are we effective? So there's always a reconnecting back with the advocates. The communities are constantly shifting. There's always changes going on. If you look from month to month, and so are we still meeting the needs of the community? Has the community changed in a way that we weren't aware of? What are the trends and the shifts, and what do we need to do internally to make sure that we operationally prepare so that our advocates are truly reaching out in the way we want them to reach out? And that just plays into constantly taking the pulse, because that landscape's always changing. If we weren't always taking the pulse from those who have expertise and working out there, again, day after day after day, it's very easy to lose track of your advocates because they're remote, and when they come in very with purpose in mind, usually to complete some paperwork, set up appointments, and to go back out again. So making sure that we constantly reconnect with our staff and are aware of the kind of feedback they're receiving. That'll be so important as we're rolling out this new program, and understanding, are the materials we're using effective? What's the pushback? Why aren't people interested? Where's the resistance? All of that pulse has to be taken in the community by the advocates, or in this case, the navigators and the assisters that are day in and day out working with people and talking to people. So, again, we are very excited to have this opportunity to be a connector. I feel like we are well established when it comes to cultural competency and diversity. We don't take it lightly. We don't take it for granted that you can become obsolete and lose the pulse very quickly, so it is always on the front burner. And our staff, to be honest, make sure that we're well aware of what's happening and what the needs are of the community. They're very passionate. So as we move forward with a new workforce, some of which will be probably part of the existing team at HCAM, we are excited to take on the challenges and work with the exchange and trying to really penetrate all three jurisdictions that all have very differing needs and very different communities. So again, thank you for the chance to talk a little bit about healthcare access.
Thank you so much, Sheila. That was just incredibly helpful, and I don't know about everybody else, but I'm going to put a big sign up in front of my desk that says translating versus communicating, because I think that is a core message that we should all keep in mind. We're now going to open the phones and allow questions, and I'm sure there are going to be a lot of them. So, Zenobia, if you could explain how that's going to happen.
Sure thing, Lenny. Everyone's going to hear an automated voice that says Q&A session has started. And to ask a question, you press *6. When prompted, you press 1 to enter your question into the queue. And then when you're prompted, you'll state your name, your organization, and your question. Lenny and our speakers will provide answers to your questions. So if you would like to join the queue, please hit *6 and then 1.
So while we're waiting for the questions to queue up, and don't be shy, I wanted to track back because so much was covered, but I think key to all of this is actually evaluating the success of the cultural competency and strategies going forward. So maybe for Leslie and Danielle and Mara want to weigh in, how will the exchange evaluate its compliance with the federal standards? And I think of even greater importance for those of us working on the ground is how will the effectiveness of the training and the connector entities be evaluated? And I know that that the exchange is overwhelmed with work, so I may not anticipate an entirely complete answer here, but along the lines of the assessment tools for materials, are there things in place?
So, Lenny, Danielle had to step away, but I'll start partially answering the question until she's available. So, as you know, we will have each navigator or sister or whatever the worker is that is going through certification will have to take a test in order to become certified or licensed. So that will be our first step to evaluate whether or not the worker has the appropriate skills. However, I think as Sheila mentioned, it's important that it's just not going to be in one classroom or one session where you learn how to be culturally competent. So the next part after, the person is able to take the test, it goes to the oversight of the connector entities and making certain that as a program we have monitors in place to ensure that the connector entities are reaching the appropriate populations. And some of that information is going to come from the community itself. If we hear feedback through complaints or just information from consumers, that they're not being served, we'll have appropriate staff in place to work to ensure that the connector entity and or that partner comes up to be compliant. So it hasn't, like you mentioned, hasn't been developed totally at this point, but we will have oversight of the connector entities and just oversight of all of our contractual partners, like our language line and things like that, to ensure that that there are measures there and that we are evaluating those measures and making certain that, they are being successful. So I think that it's always going to be a work in progress, and definitely about collecting information, evaluating it, and getting that feedback out to, those consumer assistance partners so that we can improve upon it.
Great. Thanks very much, Leslie. Zenobia, have we got questions?
We don't have any questions in the queue at the moment.
Can I chime into that, answer that one, Lenny? This is Mara.
Absolutely. Thanks, Mara.
Great. So I do think sort of looking at quality metrics is an important aspect of all of the assistance that's going to be provided. And so, as folks mentioned, the exchange can set those up and sort of, doing quality control monitoring of call center staff and interacting with interpreters. We also want to see for those providing the direct consumer assistance that, you might have quality metrics in place. I think as Sheila mentioned, you might have some shadowing, some ability to sort of monitor what's happening in the field. And we do want to make sure that sort of the quality metrics aren't just based on sort of a number of touches of consumers or things like that, but it could look at just not only how many consumers were assisted, but, how many of them submitted complete applications, or how many of them did file complaints and what was the resolution of the complaints, how many times were language services provided and was it effective? Did the same consumer have to call the call center after talking to an assister? That may indicate not all the information was communicated effectively. So I think there are a number of ways that you could look at setting up ways to monitor the effectiveness. And at least also on the federal level, even once a navigator is certified, there will be continuing education requirements. And so you could put some additional topics or issues in continuing education that may not have had sort of enough time in the initial training programs if problems arise or you see that there's trends of issues that arise.
Thank you, Mara. That's very helpful. So before asking if there are other questions, let me put it back, if I may, to you, Leslie. And the Exchange Board is putting together a consumer assistance group to respond to issues. Is this, in fact, the type of thing we could anticipate that they would be addressing?
Absolutely. That this is definitely one of the areas that this group would look into if there are any, I'll say global, but even pocket issues that come up. Definitely this is an area that group would review, analyze, and bring back recommendations to the Maryland Health Benefit Exchange so that we can take the appropriate action.
Great, thank you. Zenobia, anybody with a question?
There's nobody in the queue right now. So if anyone has a question,
in the queue, what's on here?
*6.
What's the matter? Hello?
I'm sorry, are you on the Coalition's webinar?
I'm on the webinar, and I'm in the queue, and I've pressed all the right buttons, and they keep saying there's nobody in the queue.
Oh, well,
okay, well, you're live, so
please ask your question. No one's showing up in my queue, but please ask your question.
Well, all right. There's some kind of glitch there. I'm Susan Cochran with the League of Women Voters, and
Hello? We just lost her.
Hi, this is Sarah Pomerantz from the University of Maryland. It just told me to go ahead and ask my question. I'm sorry if I'm cutting someone else off. Would you like me to go ahead?
Sure, go ahead, Sarah.
Okay. I'm a graduate student at the School of Public Health here, and I was interested in hearing more about the tool that will help people submit the application in other languages, such as Chinese. Is that a tool that is a web-based tool? Is that tool being evaluated for usability with these diverse populations? I'm just interested in hearing more about that. Thank you.
Sure. So this is Mara. Tool may not be the right framing of it, but this actually was done for Medicare Part D for applications to the low-income subsidy. What the federally facilitated market does not want and can't handle is getting an application submitted in multiple languages. So it can handle an application in English. It can handle an application in Spanish. Beyond that, it doesn't have the capacity to sort of take a Vietnamese application and then translate it into English and then process it. So the tool will actually, at least as I understand it, be sort of a translation of the English application. So you'll be able to match up question 1 on the English application, what is your full name? And that will then appear in Vietnamese. And then you can use it to sort of match up and go to question 1 on the English application and fill in the information in English. So the application itself, at least a single streamlined application developed by the federal government, there was focus testing on literacy issues. I don't think that there was focus testing on non-English languages, although we had asked for that. So it's really not an issue of sort of creating something new, but it's taking the actual single streamlined application, translating it into at least 7 languages, and then using that as a tool to help fill out the English or the Spanish one if you wanted to fill out the Spanish. We certainly hope in future years we will get more than a tool, and that someone will be able to submit an application in multiple languages, but this is year 1. I believe it's going to be a translation of the paper application. I'm sure there'll be a PDF so you can print it out from the computer, but it will not be an online application.
Great. Thank you, Mara. Did Susan Cochran make it back on?
I'm not sure if I can do that, but I can move on to the next caller.
Okay. Thank you.
Mm-hmm.
This is Betty Lamb with Montgomery County. I wanted to ask if the navigators and the assisters, are they going to be trained to work with small businesses?
So this is Leslie. Thank you for the question. Yes, the certain connector entities have agreed to have both individual certified navigators and shop certified navigators. In either case, whether they have certified shop navigators, the individual navigator will be trained on how to have appropriate handoffs to a shop navigator to work with small businesses.
So the
short answer to your question is yes.
Okay. So the connector entities then are not the entity that will work with small businesses.
So we are not So we are not disrupting the current structure. So today, typically, agents or brokers or producers are the ones that typically work with small businesses, and they will continue to do so. Only in the event that a small business doesn't have a relationship, perhaps, with a producer, that they may go through one of the connector entities.
This is Lenny, and Leslie, correct me if I'm wrong, but I believe that since Betty's in Montgomery County, the Montgomery County Department of Health and Human Services is coordinating the facilitation, if I can say, of enrollment in the shop exchange.
Yes, that's true.
Okay.
Zenobia, other questions?
I'm going to move on to the next caller.
Okay.
This is Virginia Rosa from Legal Aid. Can anyone hear me?
Yes, you're on.
Very good. I'm an attorney with Legal Aid, as I mentioned, and I just wanted to, this is a question for Sheila Makritich. So first of all, Ms. Makritich, I think you guys have a wonderful staff with respect to serving the Spanish-speaking community in the Baltimore area. We have just had really impressive experiences with, interacting with your staff. So kudos to you guys for just really having great cultural competency. My question for this is, when I looked through your partner list during your presentation, I didn't, other than Baltimore Medical Systems, I didn't really see folks who focus on linguistic access. Maybe I'm sure I might have missed something. And I also wasn't sure that I saw any that focus on Baltimore County or Anne Arundel County. So I was wondering about that, first of all. And then I was also wondering how you guys are going to approach communities that are not Spanish speaking. Thank you.
Well, thank you for the kind words about the staff, and I'll definitely actually pass that on. They will appreciate it. So, there was still, funding constraints. So with regards to our formal partners, we had to kind of pick and choose and make sure that we spread the funds as much as possible and try to reach out and as best we could, knowing that we would then, on the back end, have to address some of the questions you've raised. So with regards to how will we meet the needs of the Latino communities in Baltimore County and Anne Arundel County, as well as other ethnic communities, with regards to the Latino community. So as we're hiring, we are hiring 33 certified navigators at HCAM. They will not, for the most part, many of them will be deployed out into Baltimore County and Anne Arundel County, as well as we have a contract with an organization that's hiring 10 certified navigators, and in our discussion, she will have a very diverse staff. So from a planning perspective, that's what we're focusing on to try to make sure that we meet those needs. We've actually just recently met with the Anne Arundel County Health Department and Department of Social Services. We're meeting with Baltimore County's DSS and local health department next week, and that is much of the conversation. So they are very familiar with their pockets of ethnic communities, and we're talking now about how do we best address that. So that'll be part of the planning over the summer. With regard to other pockets, so for example, Baltimore County has pretty large Asian population, and that's something we're also trying to internally address, working with Baltimore County Health Department and DHR, who have much more familiarity with them on what's the best way. I don't know that the answer is hiring someone that can directly communicate with them, because what we're hearing is there's many dialects and not necessarily is that the answer. So I don't have a specific answer. I can tell you it's on our radar, and we've had already lots of conversations about it.
Mm-hmm. Yeah. Thorny issues, thorny topics. Well, we look forward to continuing that dialogue with you. Thanks so much for your work on this.
Oh, thank you.
Thank you. I think we need to move on if we're going to stay on schedule, but for those who may have questions now or as questions arise, we're going to have all of the contacts for our speakers on the website when we post this presentation. I want to thank them for participating today, just an enormous amount of information sharing that I know everybody appreciates. A couple of things as we wrap up. First of all, anybody who knows the coalition knows that our sort of tagline is stay informed and get involved. So we do hope, if you're not now a member of the coalition, either as an individual or an organization, that you will join. The more voices we have, the stronger that voice is. And the members do get updates on all of the upcoming presentations. We are happy to provide resources or to speak in an event that you are organizing, so don't hesitate to get in touch with us. We would also encourage you to sign up for the Maryland Health Benefit Exchange newsletter that comes out every Friday that has lots of great information on it. And as I mentioned earlier, we are going to post the recording from today and the PowerPoint presentation itself on our website, mdhealthcarereform.org. It will be under the events link, and there's other information from past programs as well, including the original, the first webinar, which was the big picture. And just a few websites, if you're not familiar with these, again, marylandhbe.com to sign up for their very informative and useful newsletter. And, of course, the public site it's up now, but going really live by midsummer, I think, marylandhealthconnection.gov. And then watch for information on our two upcoming webinars in this series. The next one, we will focus on culturally competent providers and health literacy in the era of healthcare reform. That will be a late summer or early fall. And then the last one, we will really focus on health literate consumers. After all, if the consumer doesn't know what to do with their insurance card and how to access high-quality health care, we won't have received or won't have achieved the culture of health that we all want in Maryland today. So And the last slide, just the contact information for all of us. We all love to get questions and give answers, so don't hesitate to contact us. And again, I just want to thank our speakers. You just did a terrific job, and I know everybody that participated is most appreciative, and no one more so than the Women's Coalition. So we'll see you back on a webinar late summer, early fall. Thanks again. Have a great day.